Okay, going to start now. Welcome, everybody. It's a pleasure to be here with physicians and healthcare professionals from around the globe. This is session number 6. And actually, it had 7 conferences already. The first one was Dr. Hayato Kurihara and Dr. Lilian Abo. So this conference is supported by the Panamerican Trauma Society, the American Association for Surgical Trauma, the WCTC International Relations Committee, the World Coalition for Trauma Care, and University of Miami, and the Virginia Commonwealth University, VCU. We have multiple participants from around the world here, and a pool of panelists are going to be joining us. Remember, if you are in this conference, we agree to have this imaging, the recording here at the Panamerican website. And also, please be aware that your comments, your questions, and your words are going to be public and can be used by media and etc. Now, I'm going to introduce the international group of panelists. We're going to have here Dr. Roy Coimbra, may not join today, but he's the president of the World Coalition for Trauma Care, Surgeon-in-Chief of Riverside University Health System Medical Center, Professor of Surgery, Loma Linda University School of Medicine. Dr. Thomas Scalia also is another representative by one of our societies, the Panamerican Trauma Society. He's the professor of surgery at the Maryland University and a Surgeon-in-Chief of Baltimore Shock Trauma. Dr. Felipe Vega Rivera is the president of Panamerican Trauma Society, is a surgeon in Mexico City. Dr. Michel Aboutanos is going to join us later also. Is the Fletcher Emory Ammons Distinguished Professor of Surgery and Chief of Division of Acute Care Surgical Services and Medical Director of VCU Trauma Center at Virginia Commonwealth University Medical Center. So all these are the representatives from the model institutions, the main institutions. And now I'm going to introduce the panelists. We're going to have here with us Dr. Lilian Abo from the University of Miami, Dr. Matthias Lobi from the University of Miami. Also, he's the Chief of Transplant, Heart and Lung Transplantation, and Mechanical Support at the Miami Transplant Institute. Have here also Dr. Faisal Massoud from Houston, Texas. Dr. Massoud is the Medical Director for the Center for Critical Care at Houston Methodist Hospital, Professor of Clinical Anesthesiology, Weill Cornell Medical College, and Medical Director of Cardiovascular Intensive Care Unit at Houston Methodist DeBakey Heart and Vascular Center. We have here with us also Dr. Hayato Kurihara from Italy, Professor at the Humanitas Research Hospital, Head of Emergency Surgery and Trauma Section of Department of General Surgery, Università di Milano. Also Dr. Alessandro Giaccheri, Emergency Physician at the Emergency Department of Fondazione Cagranda, and physician at the Ospedale Maggiore Policlinico in Milano, Italia. Have here again also Dr. Rafael Barreira, Director of Global Surgery and Professor of Surgery at Northwell Surgical Service Line and Director of Surgical Intensive Care Unit at the Long Island Jewish Medical Center. Dr. Alan Gu, going to connect also from New York, Professor of Surgery at St. Jacobs School of Medicine and Biomedical Science, Buffalo, New York. Dr. Sanjit Kaul, Chief of Trauma at Hackensack University Medical Center, New Jersey, a member of WST. And probably Dr. Ali Jafarian from Iran. He's present last week. He's founder and chief of division hepatocellular and pancreatic biliary liver transplantation, professor of Department of General Surgery, School of Medicine, Tehran University Medical Science in Tehran, Iran. Okay, so I'm going to start now. I have a pleasure to show now our affiliated entities and societies from around the globe. Valeria going to show have all the societies presented here right now are affiliated to the Panamerican Trauma Society or to the WST or to World Trauma Coalition. So It's a pleasure to have all these societies being part of this webinar. It's a pleasure to have so many bright minds around the globe join us and discussing this situation with COVID-19. So to start the presentation today, I would like to invite my friend, Dr. Lilian Abu. Dr. Lilian Abu is the Chief of Infection Control Antimicrobial Stewardship at Jackson Memorial Health System. She's also a professor of infectious disease at the Department of Medicine at the Miami Transplant Institute. She works at the University of Miami Miller School of Medicine. I had the privilege to work with her, and she's one of the best human beings and the best physicians that I ever worked with. I'm sure they're going to be delighted with her presentation today. Dr. Abu, please.
Thank you, Dr. Marttos, for the very kind introduction, and thank you everyone for being a participant in this meeting today. So my part of the talk is the current protocols and strategies that we have for COVID-19. And I have a few disclosures. The first one is I am not a trauma surgeon, as you all heard. We started our COVID-19 preparedness way back in January of this year. And since then, I have not taken a day off. All the information and all the protocols that you're seeing here change every 6 hours. So we start the day at 7 in the morning with a whole plan of how the day is going to go. And by the time it's 3 o'clock and we have a leadership call, half of the things have already changed. So it's a very fast environment. And what looks like we've been doing for a year, it's only been a few weeks. And this pandemic is very close and near and dear to my heart. And it has affected my family, my personal friends, and we have lost coworkers. So yes, it's a tough virus, but we're here and we're gonna fight it until we can conquer it. I just wanna put some pictures of where we are, and so you can understand the complexity of our health system. Jackson Memorial Hospital is one of the hospitals of the larger health system that I have the oversight for infection control and stewardship. Our main hospital is licensed for 1,550 beds with 270 ICU beds, including neonatal, one of the largest neonatal ICUs. We have a very large solid organ and trauma program, as well as a children's hospital and a mental health hospital. In addition to that, the system also has 2 community hospitals where they're non-academic, and we have around 600 beds, 600 to 700 beds between the 2 hospitals. We have 2 long-term care facilities, and whenever these patients get sick, they come to the hospital or go back to the nursing homes. And then I also have the oversight for the infection control piece of 4 of the Miami-Dade County jails. And I bring the jails here because we also have around 4,000 to 5,000 inmates. We have around 400 healthcare workers and over 2,000 corrections officers. All of them, whenever they get sick, they get back to the hospital. So it's a very, it's a mini city, I would say, with over 12,000 employees and over 500 University of Miami faculty. We started our protocols way back in January, and these protocols are multidisciplinary, they're very comprehensive, and we update them weekly. But just to give you a timeline of how things have evolved, and this affects how we're treating our patients, we started in January with triaging all our entry points with a questionnaire, have you traveled to China or Asia, and then expanded to the other countries as the epidemic evolved in February to Spain and to Italy. Then we started seeing our first PUI present in our hospital around the end of February. And fortunately, that was like a drill. The patient ended up being negative, but it helped us test our system, that the PPE was in place, that the education was in place. Within a couple of weeks later, we had our first case. And at that time, we did not have the testing available in our hospital. So we had to send everything to the Florida Department of Health, and results were taking a week or more to get back. On the meantime, you had the patient on suspected, patient under investigation. We had patients coming as outpatients. We had people coming from cruise ships, people coming from the airport. It was a very chaotic environment as people didn't know where to go, where to get tested, or how to get the results. So we very diligently, the health system starting to work on a way of getting testing in-house so we can get rapid results, identify cases, do tracer investigations, quarantine, and treat people who needed treatment. By the middle of March, we already started to discontinue all elective surgeries. We started a no visiting policy except for end of life, maternity, and pediatrics. And we started changing our attire to scrubs only or any thing that you can launder, nothing that has to be dry clean. And we implemented universal surgical mask for any healthcare worker, any person walking into the facility needed to wear a surgical mask at all times. By the end of March, we already started with some limited swabs and reagents, our in-house testing. So we shortened the results from 2 weeks to within a few days. And right now we have 4 PCR platforms. So we are able to get some of the results as quickly as 15 minutes or within an hour. And there are others that are still taking around 24 hours. We started social distancing, universal eye protection with goggles or face shields. And we are now testing slowly all our pre-op procedures regardless of risk. And by the end of this week, we're trying to test all admissions regardless of the COVID risk. We're also working on a process for returning to work employees and finding a way to safely test everyone to make sure that the healthcare providers are not infecting each other or the patients. Our personal protective equipment has evolved and we divided in low, high risk and intubation. The intubation, you really need the full gear. The low risk, we're still following the WHO and CDC guidelines. Another thing we look very carefully is at our cases, and we have visual dashboards on a daily basis looking at where the cases are presenting. So it's important to look not just at the curve, as we're seeing in Florida, the flattening of the curve. We also want to make sure that in different parts of the county, we look at different demographics and risk factors. For example, in the northern part of Miami-Dade County, we're seeing a very different situation than in the southern part. Here's where we have one of our community hospitals. Here's our main hospitals, the jails, and here's where we have the other community hospitals. So in the northern part, about 33% of the patients that we test come back positive. We're also seeing in that area that patients are presenting late, many of them elderly, with comorbidities, or a little younger, obese, with some other comorbidities, and many of them present and within 24, 48 hours are severely hypoxemic with a higher number of deaths. Where we're seeing in the other parts of the county is around 20% positive, and that rate has remained stable for the last 10 days. In the nursing homes, we have some nursing homes in the county that are showing outbreaks, and that has to be monitored very closely. And then in the county jails, we have been doing surveillance and contact tracer. As you can imagine, those are environments where it's very, very hard to maintain social distancing, and we need to be very careful when we start implementing measures. Moving on, I want to show you what our daily dashboard looks like. This was the one from last night, and we have tested around almost 7,000 people, 6,894 patients, with an overall mortality across the health system of about 5.8%, and the total number of positive cases is about 17%. But as I mentioned, depends on which hospital we're looking at. If we look at the pediatric hospital, the number is very, very small. It's less than 5%. But if you look at the hospitals that are closer to the nursing homes and a different demographic, it's a higher population. We also are looking at our trends. We're noticing that the majority of our patients now are non-ICU compared to ICU. And we're also looking at the ventilator, and we're looking at the number of patients that are on a ventilator by hospital. And we're looking at the ventilators assigned to COVID patients. So we are way below our capacity. We have not reached what New York or other cities in the world have seen, which is a surge and unable to take care of the patients. We also have our daily trends of the number of positive cases and the patient's pending results. And as you can see on the left bottom corner, our lab results have decreased the number of positive cases, but we are seeing a slow uptick in the mortality. We have a very large Hispanic population in Miami, and this is shown here. And as many have noticed in other parts of the world, this disease seems to affect male more than female. So women are tougher surviving this. One of the concerns that we have is the viral dynamics and transmission. Initially, the first reports came from China. We understood that this was contagious for about 14 days, and most people would then probably develop some antibodies, and we don't know about the long-term immunity of this infection. What we're seeing now is even on asymptomatic people that we have tested, they seem to persistently have positive PCRs beyond 14 days. And we don't know if they're truly just contagious for the first 7 to 14 days, or the positive PCR continues to shed virus, and how fit is this virus. Others propose that between mild and moderate symptoms or severe symptoms, you're probably going to be more contagious for a longer period of time, up to 25 days. In some reports from Germany, they're saying up to 45, and I think there's one case up to 60 days. And then in those critically ill, it seems that they're going to be also very, very contagious, also until the time of death. So I want to bring this to your attention because we don't know yet how contagious are we, and we don't have viral cultures in every one of these cases to determine that by the time you have no symptoms, you're really not spreading any more disease. Some of the dilemmas is, for how long is this PCR going to be positive? Is it different if you're symptomatic or asymptomatic? Can you return to work just based on symptoms? And is it safe if you just put on a mask and you go back to working in your trauma ICU or in your ER? What is the correlation between the viral fitness? What happens when we have false negative, and how many times do we need to repeat the PCR without collapsing your lab and your supply chain? And then different performance of different tests. And it has been all over the media in the United States. A new platform from Abbott seems to have a lower sensitivity, and the swab is inhibited by the viral media. So now they're recommending that you put directly the swab from the patient into the instrument. So as clinicians, you need to know which platform your lab is using in order to better interpret the test. The other test that is coming out is the serology, and there are different serologies. None of them initially were FDA approved. Now a couple of them are FDA approved. This is one that we acquired that it's not yet FDA approved. It's available for research. But I just want to show you in patient one, we have someone who was asymptomatic but was in close contact with a COVID patient. The PCR was positive. And then what we found out is that after 27 days, more or less, this person had a PCR positive and already had IgG positive, which means convalescent. Patient 2 started with symptoms also about 3 to 4 weeks ago, only dry cough, never had a fever, no shortness of breath, no hypoxemia. But this person was tested, and still after 26 days, the PCR is still positive, and we're seeing a band of IgM, which shows early antibodies, and IgG. So this person is still contagious. This one, what do we make out of this PCR? It's just dead RNA and not contagious, and can this person return to work? So IDSA just published this week a primer on antibody testing. It's available on the Infectious Disease Society of America website. And they're suggesting that we should not be using serology for the diagnosis of acute infection to guide treatment, but mainly to detect PCR negative cases, convalescent plasma donor, if you're doing population health epidemiological studies. Now, getting into the treatment zone, which is what we all want to hear, one of the concerns we keep listening is, as we started early in this pandemic, we didn't know what could work, and a lot of things were done empirically without any evidence. And now as more reports are coming out, like today, a paper came out of the VA looking at hydroxychloroquine, we really need to think as a society and as a community of scientists are we putting more fuel to the fire? Are we really causing more harm by trying new drugs and new treatments, or are we really helping these patients, or were they going to get better without a proportion of the population may just get better doing nothing? So the IDSA published guidelines last week with 7 recommendations. And in those 7 recommendations, they pretty much said that anything you're going to do should be under the auspices or the context of a clinical trial if the patient is hospitalized. The problem with that is in community, non-academic centers, it's not so easy to do a clinical trial on every intervention that you want to do. But this really has to make us thinking, what are we doing and how should we be doing things? And they recommend that if you cannot do a randomized controlled trial, at least start a collaborative registry so we can systematically evaluate all these interventions that we hear every week on a different webinar, and people adopt very rapidly the evidence. You have 6 patients treated with azithromycin, the entire world started using azithromycin. So as of last night, there are 745 studies in clinicaltrials.gov, 144 in the United States, 246 in Europe, and the rest in Asia and other parts of the world, really trying to answer all these questions that we all have. And I do antimicrobial stewardship, so I think of COVID in the same way. Is this something that we should have a protocol and have a cooking recipe for everyone? Or in some patients, we really need to avoid protocols and individualized care, and it should be like a tailor-made suit. We really need to look at each patient individually and what works and who needs anticoagulation, who doesn't, and who needs which therapy. So I bring this question to the panel and to the rest of the listeners to try to think in that sense, who needs a protocol and who needs individualized care. When we look into the NIH just published yesterday the guidelines for the treatment of COVID. It's a very rapidly evolving situation, so I'm sure that these guidelines, 5 weeks from now or even 3 weeks from now, may be looking completely different. But the panel is not recommending pre-exposure prophylaxis for severe ARDS or outside of a clinical trial, and they're not recommending post-exposure prophylaxis also outside of a clinical trial. And again, no drug yet has been proven to be safe and effective for treating COVID, so there is insufficient data to recommend for or against anything. For asymptomatic patients, the NIH is recommending self-isolation, and they're saying that if you're fine after 7 days after the first positive test, you might be able to discontinue. I feel that I'm concerned with this recommendation, and I am not sure that without availability of wide testing and understanding the immunity of this disease and how long the PCR is positive, that a lot of people are just going to go out and keep infecting others. So I'm not in complete favor of this recommendation. They also recommend no additional lab testing or treatment for anyone confirmed or suspected of COVID. So I don't know how we can implement safely this as we try to reopen cities and create a new normal. For mild illness, the recommendation is that they should be closely monitored at home, try to avoid admitting patients, but understand that some of these patients may progress rapidly. They're not recommending routine laboratory testing, and they're saying that there's insufficient data for immunomodulatory therapy or any type of antiviral therapy, and that's a strong recommendation. For moderate illness, you have to assess based on the hypoxemia, and they're recommending hospitalization with close observation, but again, insufficient data for any therapy. And then for the critically ill, there are insufficient data to recommend against or for any type of therapy. They recommend against the routine use of steroids. And if the patient is mechanically ventilated, you have to be very careful in who are you going to use corticosteroids unless they're in refractory shock or using a low dose corticosteroids in the patients who are chronically on steroids. So I think that's another important point where there has been a lot of controversy. So what are the current treatments under investigation? They have all been discussed in the last few weeks in these webinars: hydroxychloroquine and chloroquine and remdesivir. We are not able to get remdesivir. This currently is only under the expanded access compassionate use, and very few hospitals in Florida have it. And then they're recommending against the use of hydroxychloroquine plus azithromycin due to potential toxicities unless you're doing a clinical trial. And I think this is very important. So I want to urge people to really avoid the combination of azithromycin unless you're doing a clinical trial, and avoid the HIV medications. They're also recommending that convalescent plasma or hyperimmune globulin should be done very carefully under a clinical trial, the same way for IL-6 and 1 inhibitors. And they're recommending against interferon or JK inhibitors unless you're going to be doing a clinical randomized trial. So they favor the top recommendations versus the bottom ones. These are other therapeutic modalities that are currently in clinical trials that we are trying to expand at the University of Miami and Jackson Health System: the use of stem cells, the use of convalescent plasma, nitric oxide, and plasma exchange. All of these, again, has to be done under the context of a clinical trial to understand what are we doing and why are we doing it. And then just to finalize in my last minute, I want to mention that this pandemic has come very, very close to my heart. This is my first mentor and my uncle. He was my patient. He presented with COVID and very rapidly, in less than 24 hours, went into full ARDS. He initially was treated with tocilizumab, and we actually gave him Prograf and steroids as desperate measures. He decided to be DNR and DNI, and he knew what was happening and was alert and oriented at all times. It was heartbreaking to be the only family member and the only physician who could be at his his bedside. And he was a rheumatologist and the founder of rheumatology in Venezuela and the medical director of my medical school. And it's ironic that as an infectious disease physician, I was in charge of treating a prominent rheumatologist who's my beloved family member with anti-rheumatological drugs that none of us really knows how to use, and we're all experimenting. He was also the founder of evidence-based medicine. So what I want to do in his memories, and I urge everyone that whatever we do, we try to create some evidence. It's very hard when you're in the middle of the storm, but as we're now trying to see the storm calming, this is the time to pause and think, what is the right thing to do so we can truly save lives and you know, learn from this pandemic. So a pessimist sees the difficulty in every opportunity, but an optimist sees the opportunity in every difficulty. So let's think globally and conquer this pandemic together. Thank you.
Dr. Abu, thank you for a great presentation. Again, a lot of data, a lot of information, and I can guarantee the discussion is going to be very, very good here, which especially some people treating these patients in ICUs and in Europe and in the United States. So we're looking forward to their experience and their reports. Let's go now straight to Dr. Hayato Kurihara, University of Milano. Dr. Kurihara going to give his update about, he was the first one that we met 7 weeks ago. And now Dr. Kurihara going to see what's happening in Italy, Dr. Kurihara.
Okay, thank you, Antonio. Here is my very short presentation. I think that the main focus today is on treatment. So I just would like to give you some very brief update of what's going on at the moment in Italy, with a specific focus in Northern Italy. So as you see, these are the data of yesterday from our health institute, National Health Institute. The total number of positive cases is nearly 170,000 people. What is quite astonishing is that 18,000 of healthcare workers have been infected. Just to give you an idea of what's going on in my hospital. In my hospital, no intensivist has been infected, no nurse in intensive care, but we had quite a lot in the emergency department. And it's quite amazing, 1/3 of the surgeons got infected. And this is not really related to the fact that we have been in contact with patients, but we are all stuck in an open space when we work. So we infected each other. That's the sad truth of what's going on. And we had more than 20,000 people that died. Well, you know that most of the people they develop mild signs of infection, but 20% are quite severe, and 2.2 are in our ICU. Again, what we could see in Italy, mortality between 50 and 59 years, it's quite high because it's still 2.5%, and this is quite healthy population. And of course, the most frail patients are the ones that are exposed to higher risk. This is a chart regarding the distribution of all of our region. As you see, the top player, unfortunately, is my region. It's Lombardy. More than 56 patients that died from COVID, they died in my region. That's the first region that underwent to a total lockdown. We tried to contain, but unfortunately, before the official closing of the lockdown, some people moved to other regions. And as you can see, the median age of people that die, it's quite high. But still, we have some younger patients, as you know. So these are the characteristics of the people that die from COVID-19. It's, you know, ischemic heart disease. Most of the patients had some associated morbidity with ischemic heart disease, cardiological problem, stroke, or hypertension, and diabetes too. I would like to report, this guy is a vascular surgeon from my hospital, Paolo Spada, who actually at the moment he is contained at home and for quite a long period, and he decided to try to help us, giving us a daily report on what's happening all over the country. And so as you can see, at the moment, 44 of patients are isolated at home. We got some troubles to try to isolate these patients. So many hospitals had to organize themselves to find a place where to send the patient to. And this is one of the most challenging issue that we are facing with. It's not an easy case sometimes. So at the moment, 13% of infected patients are admitted to hospital. The total ratio of death, as you see, it's quite high, 14. And 28% have been fully recovered at the moment. And this is a projection on what we are expecting. Till now, the projection that have been developed by Dr. Spada were quite accurate. So we are seeing a slow decreasing of infected patients. And we are really very anxious because on May the 4th, we will probably finish the total lockdown of the country. But and we hope that within this week, the Prime Minister will communicate to the people, to the Italian people, what will be the modality of the so-called stage 2 scenario. And finally, we are having some relief in the past weeks, since for the very first time, we do not lack anymore so much ICU bed. As you know, at the third week of March, we had the peak of the need of ICU bed. So all over the country, we had to look for ICU bed. We had to transfer many patients to other regions from Lombardy. We have been transferring also some patients abroad, like in Germany, well, quite few patients, but mainly to other region near Lombardy. But now things are slowly improving. And as you can see, we have a decrease of patients in ICU and a decrease of patients in the ward. So from these weeks, for example, in my hospital, we were a hub for surgical oncology. So we didn't stop completely surgical oncology. And from this week, we are slowly reopening the OR for selected oncologic patient. And as previously reported, we developed a triage system for surgical oncology patients. And we have no idea on when we will start again to have elective surgery for benign surgery. And at the end of June, we will, the new hospital totally dedicated to COVID patients will be finished, hopefully. And it's going to be a hospital with the specific pathway for the emergency patients and ICU and critical care medical ward. And we will also have an angiosuit, CAT scan, and a dedicated OR for patient with COVID patient with acute problem. But we are very curious regarding what's going on from next week, in 2 weeks, sorry, regarding the end of the lockdown.
Prior to the peak, during the peak, now you're glad to see that the things are getting better in Italy. And it will be very important to show us what's happening during the reopening, the recovery phase, and for sure we're going to learn a lot with you. So let's go right now. Yeah, you're gonna learn a lot. Dr. Alejandro Iaccheri from Italy, also from Fondazione Granda Ospedale Maggiore Policlinico Milano, Italy. Please give your report and so your findings on how treating all these patients, please.
Okay, thank you for your invitation. I'm glad to be here to explain our experience. First of all, I would like really to thank Dr. Abo and Dr. Curiara because they almost made the job. So my job will be very easy thanks to their presentation. So I try to understand what are the actual therapeutic approach. And so I will try to introduce you to this medical world. I know that the most part of you are a surgeon, trauma surgeon, and so maybe you don't get used to much with medical and infection disease therapies, but as we had to an hospital, Humanitas Hospital in Dr. Curiara, had to learn about how to use drugs in this field. Even in the rest of the world, probably is important to have some ideas. First of all, I would like to explain that we are facing the unknown. The COVID-19, the SARS coronavirus 2 is a new virus. It's something that we discovered just a few months ago, and everything is still very, very unclear. There is a lack of evidence about everything, and there are no big clinical trials yet. There are some ongoing, but not yet is still published. So there is no therapy yet approved to treat COVID-19. That should be very important to keep in mind. So we have many options in our hands, but many options doesn't mean that we have solutions. Because first of all, we have to understand if all those options, those treatments are really safe. And we have to understand if they have some adverse effects. And this could be important even for the burden of these effects can be on the patient. So I remember that our first rule, wherever in the world, should be do not harm. No, this is what we learn at the medical school. So it's very important to understand what are the adverse effects of those drugs. By the way, the other point is the efficacy, and are they really useful or not? Because if useless, maybe and they have adverse effect are not a good point. Are they available? I know that it's I'm talking to a lot of colleagues everywhere in the world. So I worked in other settings in my life. So I know that not everywhere in the world, all the drugs we are proposing and we are testing are available. So it will be very important to understand if those drugs will be available everywhere in the world, and if not, how to. And then the cost. I know we have different health systems. Italy have a public health system, national system. Other countries have a private system. So the cost could be very important to understand the sustainability of the therapy, especially if the pandemic will last for weeks or for months. Anyway, many trials worldwide, as Dr. Abo already showed, so we also participate to many of them, and we try to understand as much as we can before the pandemic stops, because the pandemic is a horrible scenario, but it's also those weeks are the only one we have to make research and to understand what is going on, because if this pandemic will back maybe in future, some specialists they expect maybe another peak in next fall. So most things we can learn now would be very important, especially in future. About the therapy, just a few words. Different targets it means different drugs. So I try to be more clear as possible. So we have therapies to reducing the viral load or the replication of the virus. And the first one proposed was the lopinavir, ritonavir. That is another drugs that used in HIV. Is a protease inhibitor and will block the replication of the virus. There are other drugs like remdesivir is a new drug that is tested for Ebola in recent times, and these drugs as well works on replication of the virus. Arbidol is drugs not really used in Europe, but I saw some tests even in the United States, I suppose. So they also inhibit the membrane fusion. And so the idea is also to block, to prevent the entrance of the virus inside the cells. And then finally, the famous chloroquine and hydroxychloroquine. It's a huge debate worldwide about these drugs. Is for malaria disease, for other kind of disease, but in vitro shows some results about blocking viral entry and reducing viral load. And he also have immunomodulation approach on the host. So it could be maybe a good idea, but at the moment, and then we will discuss it later, evidence are not really supportive. And about host immunomodulation, we have also glucocorticoids. That's everybody in the world knows, so sure. They have a huge kind of use, and especially in this kind of disease, we use it for repression of pro-inflammatory genes and reducing inflammation with kinase interaction. So always working, even the glucocorticoids on the cytokines pathways. Tocilizumab and anakinra are two other drugs that works inhibiting interleukin-6 and interleukin-1, and so the cytokine response. And then another drug that we are using in Italy is the apremilast, is inhibiting the phosphodiesterase, and so it works suppressing on tumor necrosis factor alpha. This is not the only one. This is just to understand, to show other colleagues that many ideas has been put on the floor, and many trials are ongoing for every one of these. And so we have, as I told before, we have really a huge amount of options, and but which is the best one? Now it's try to understand this. This wonderful image I found on JAMA just 10 days ago. It was published by Sanders and his colleagues. I think it's very nice, especially to read slowly, maybe when you're home and when the webinar is finally finished. But it's a very easy image to understand what are the pathways and the functions of the different drugs, how they act against coronavirus. Other approaches, there is always working on viral load or replication. Some studies works on favipiravir, sorry my pronunciation. The Avigan is a Japanese drug that works on RNA polymerase, and the ribavirin, that's common use in HIV and another viral. And unfortunately, or fortunately, it depends from the point of view, the first data are very bad, and so they have a lot of bad effects, adverse effects. So finally, in most of the world, we stop trying those drugs. Then there is the new approach. This very, maybe you should you may heard about the anticoagulants. Now that seems the new solution, the solution to everything. Heparin, why we didn't talk before? We had some autopsies, and we found a lot of results of thrombosis inside the lungs and the vessels. So some colleagues suppose that maybe the use of heparin could help, and some colleagues even arrived to propose the pathogenesis of the virus more linked to vasculitis or to a hypercoagulant state, and to push with the studies about anticoagulants, especially heparin, that is, you have also an immunomodulant role. So that's why the way they decide, and it's very common and quite cheap to use everywhere in the world. The idea is more an action against the DIC. But in recent studies, we already talk about sepsis-induced coagulopathy. We had some experience about heparin, but I will tell you later. The other, as Dr. Ab already explained, plasma. In Italy, we currently is under study in 2 different hospitals, the COVID-19 convalescent plasma. So people who have recovered from SARS-CoV-2, they donate their blood. and we use plasma for treat patients, especially severe patients in the ICU. I don't have in my hands some results with me. In my hospital, we are not actually using, but I heard some colleagues from Pavia Hospital, from Mantova Hospital, there are other big hospitals in Lombardy. They finally seems they have positive data, but everything is still ongoing. So it's maybe not yet time to discuss about this. What about literature? Dr. Abo already cited most of these, a lot of articles and manuscripts recently proposed and submitted to many journals. If you read or you just look for COVID-19 on the web or PubMed, etc., you find hundreds of articles, and it's very hard to understand what are the one really well prepared, really focused on the problem, and they are very good peer reviewed. So one about guidelines and review, I tried to read in the last days, and for example, this one I'm proposing is in intensive care medicine, is the surviving sepsis campaign that everyone, even the surgeon world should know. They also propose some guidelines in the management of those COVID-19 patients, and finally, those are the evidence. There are just a part of this. I just selection what about the therapy, and as you can see, there is no recommendation because there are lack of evidence in almost everything. The only weak evidences are really about against convalescent plasma, lopinavir, ritonavir. It was also discussed about lopinavir and ritonavir in a New England Journal of Medicine at the end of March. There was a big study that was published against the use of these drugs. So, but as you can see, the recommendation as in guidelines are very poor. Even the Infectious Disease Society in America, that was already cited by Dr. Abo, they don't have any kind of recommendation or strong recommendation for any drugs. So at the moment, there are evidences, we say no. The only evidence I found is very interesting. In this is some Chinese colleagues that show that interminable meetings has been found ineffective for treatment of COVID-19. So what we also made in Italy, that we met each other, we discussed for hours what could be the best treatment for our patients, etc. But the New England Journal of Medicine can testimony that they has been ineffective. What I think that probably really, as Dr. Abo said, a tailor-made therapy for patients could be maybe the best solution. Our experience in Policlinico in Milano, the university hospital, in all COVID-19 patients, we provide hydroxychloroquine for 100 milligrams oral twice a day for the first day, and then 200 milligrams twice a day. At the beginning, we start with lopinavir, ritonavir, and finally we understand after some new evidences, then we decide to stop. What happened next? Then patient with the high flow oxygen, so Venturi or CPAP that we use it's very easy in Italy to use CPAP with helmets. There's something that abroad is not very used. People prefer non-invasive ventilation, but anyway, and high level of ferritin, we start anakinra, so the anti-interleukin 1, and we also add the methylprednisolone. So about corticosteroids and glucocorticoid in general, there is a lack of evidence. Some studies are more promoting the use, especially in severe patients, and they have a few evidence that could be better for that for them. But in the other way, especially in infectious disease specialists, they are very I say scared to use because they have in their mind the adverse effect of the therapy. But we with our infectivologist and rheumatologist, immunologist, we decide to try it with this. And just in patients who undergo to ICU invasive mechanical ventilation, or just in compassionate use for young patient with no other chance or they get worse. We also tried remdesivir, and both are under current investigation in our hospital. So I hope to have soon some data to present to the community about this. What is important in our experience in Italy, we also use the heparin. We use the heparin, the enoxaparin, that I think most of you should know. We use the 4,000 units subcutaneous day. If patient, obviously if they have deep venous thrombosis or pulmonary embolism, we use the normal decoagulation dose, but there has been a huge discussion in Italy about the use of the enoxaparin, how to use if 100 units per kilograms, or 70. Some studies also propose to use the 70 units per kilo. That is a middle dose that probably doesn't show any kind of evidence in their use. And finally, in our hospital, we use this kind of protocol, and we had with the preventive, just enoxaparin 4,000, we didn't found a lot of embolic, but also we don't have a lot of autopsies in these pandemics. Autopsies has been reduced to the minimum, unfortunately, because they are they bring with them a lot of information about the patients. But at the beginning, when some patients were decoagulated with double dose of enoxaparin, we had a lot of bleedings and other complications about the use of decoagulation. So we are not actually sure in our experience. So there are no data. I'm not presenting data, but just our impression is that the enoxaparin should be kept just for in preventing this dose just once a day. What can I say is also that we, in our experience, had the impression that with the glucocorticoids, our patients really get well soon and fast. And that is just impression. We are now trying to understand our data, and we should split about patients who made anakinra and methylprednisolone, or the methylprednisolone alone, to understand if finally we have data to present, and statistics will tell us if it's a good idea or not. That's all. I think my colleagues already explained everything and add other information, so I try to be as fast as possible. And so if you have any question, here we are, and good luck for the rest of you that should still focus and assess the pandemics in your countries.
Thank you very much, Dr. Alejandro Iacchetti. Let's go straight to the pool questions. I'm going to have 10 questions for everybody to answer, and then I'm going to ask the panelists to discuss some of these results, okay? And some questions that they'll have on Q&A also. So Valeria, could you please launch the pool questions? We're going to see in your laptop, your smartphone, some questions. Let's try to answer these questions and then submit, okay? Then you need to answer all the questions, then click on submit at the end. First questions, what's happening in your area? We still have an increase of cases, a lot increase, a small increase, not increasing, it's plateau, slight decrease or very decrease, or you don't know. So please let me know what's happening in your region regarding the COVID-19. Okay, next question. The panelists cannot vote here. Next question. Do you have protocolized sequential treatment guidelines for physician discretion? Or also all your hospital does a protocol, follow protocol guidelines, or you can do anything you want, okay, to treat these kind of patients. Number 3, what are the first line medication that are using for patients that are positive, patient goes to the hospital but go home. So what kind, are you giving any treatment, any medication for them? Please let us know. Okay. And I can put as much, multiple answer. Put any medication given for a patient when they are positive and they go home. Okay. No, number 4, what the first line of medication they give to your patient once they are admitted to the hospital? They are sick enough to go to the hospital to be admitted, not in the ICU. Patient that are admitted in the hospital, what kind of treatments or therapies or medication to give to them? Okay. Okay, I think now the host is and the panelists can vote also. Please, panelists can vote now. Number 5, what kind of medication do you give once your patient is in the ICU, in the intensive care unit? So what do you add? What are you doing once your patient is in the intensive care unit? Please vote on everything that you are doing, okay? Number 6, are you did you often found any problem with DVT, stroke, pulmonary embolism, myocardial infarction, any thromboembolic event in your patients? Okay, there's number 6. Number 7, if you start to full anticoagulation, when do you start to full anticoagulation? As soon as you admit the patient in the hospital, when the patient is admitted to the intensive care unit, when intubation is needed, or only when the markers from thrombotic events are going up, like the dimer, or you never start anticoagulation, or you don't know. Okay, if you start anticoagulation, when do you start that? Full anticoagulation. Okay, number 8, you have multiple questions right now. So, okay, please tell the medication that you are using in your hospital and you feel that make patients improve. Okay, number 8, tell me the medication that you feel that make your patients improve. Okay. Number 9, tell me the medication that you are using and that you feel that doesn't improve or doesn't deteriorate. So the things that the patient, you don't think that's helping, but it's not making the patient worse. Any medication or treatment that you use, but you don't feel like strongly making the patient better or worse. And the last question, number 10, please tell us the medication or treatment that you did, that you used and you stopped it because you feel that give you side effects, a lot of complication, or the patient start to have bad outcomes. Okay. So tell me what you think to make a patient improve. Tell me what you think patient, you don't think anything happen. And tell me what you really think that is making patient deteriorate and you don't want to use anymore. So Rafael Barrera, you have a good experience in New York, in Long Island. So what are you using that you believe that's making patients improve? What you stop using, and what's changing through your guidelines lately since you started managing your patients, please?
Thank you. So it took us a couple of weeks to protocolize everything. So right now in our protocol, we do not use steroids. We do not use azithromycin, and everything is in an arm for research. So you can use any of the interleukin-1, interleukin-6, the anti-malarial drugs, but it has to be under this guise of research. And our feeling is that that's the only way to see if they're actually working. So most of the patients are on some type of trial and some type of investigation drug. So azithromycin for sure was causing a lot of QTc interval increase and a lot of arrhythmias. And that was the first one to stop. And with the steroids, we stopped it also. We didn't feel it was adding too much. And apparently there's some data to suggest that it increases the viral load of the patients that doesn't let it clear. So we DC the steroids. Steroids can only be used under an investigational trial.
Thank you, Dr. Barrera. What about Dr. Kaul in New Jersey? I know that you have been in quarantine. You're a healthcare professional, had the COVID-19. So tell me your experience in your hospital, please.
So Hackensack Hospital has been the hotspot in New Jersey. It's seen the most number of patients in New Jersey, primarily because it's sort of seen as an offshoot of New York City, since it's only about 10 miles away from New York City. And it's historically a 770 bed hospital, which was increased to about 1,000 beds because of some innovative means of expansion and things like that. But the trauma services role was to basically help manage these COVID ICUs. So our team, which comprised of 8 trauma surgeons, we ran about 5 COVID ICUs. Each one would have about 25 patients. And our experience is that by the time they were in the COVID ICU intubated, it didn't really matter whether they were on, whether they had received hydroxychloroquine or steroids, or whether they had been placed on the protocol drug. We are on all the protocols. We have access to remdesivir and the IL-6 inhibitors. Anecdotally, we saw some benefit on occasion with IL-6 inhibitors, but historically, elderly patients, greater than 85 years of age, we didn't really have any particular luck with any of these agents. So I think it's old-fashioned critical care, supportive care, managing secondary infections, and then having early conversations with families regarding end-of-life care and trying to have meaningful sort of discussions. So our experience did not really stand any particular drug out to sort of think that this may have made a difference. Unfortunately, that's been my experience.
Okay, thank you. So I have a question here for Dr. Matthias Lobe. Dr. Lobe, once you hear from the panelists here, once the patient is intubated, there's a tough situation. A lot of reports right now from thromboembolic events. So you working on lung transplantation, heart support, and ECMO. How do you see this disease, and how ECMO can support, can help these patients? Or a lot of discussion about fully anticoagulating these patients only when you have these kind of problems, or early anticoagulation. So please tell your opinion about how to best approach these situations. Dr. Lobe, please.
Yeah, so in our practice, based on these early reports that there might be a serious thromboembolic procoagulable state related to COVID-19, we anticoagulated all our patients on ECMO. So usually we would not do that in the VV ECMO support situation. Of course, our experience is not extensive enough to make any kind of statement whether that was really helpful or not. I think looking at a number of publications, some friend of mine just published 2 days ago in Lancet their observations from the University in Zurich about exactly this effect, that the COVID-19 makes a vasculitis on the small vessels, not only in the lung, but in all organs across the body. And they were able to, from autopsy reports, autopsy findings, to document that. So I think it is true that in our therapy, we anticoagulate them, but otherwise it's old-fashioned ICU supportive care, as has been said. That's all we can do right now. Initially, there was hardly any autopsy work done in these patients. Unfortunately, the CDC made a misstatement recommending not to do autopsies on these patients. Again, this paper from Zurich, or it's a letter to the editor, or work done in Hamburg, where they did more than 100 autopsies in patients who died from COVID-19, very much suggests that there's a very strong vasculitis component that leads to the death of these patients. So probably we have a subset of patients, and those are the ones who do very poorly, who develop where the virus leads to this systemic disease that we at this point really have very, very difficult ways to influence other than just simple anticoagulation.
Thank you, Dr. Lobi, for your report. Dr. Abu, you saw the results of the pools, right? So, and looks like chloroquine and not chloroquine, azithromycin are they're very different or very polarized opinions. Work, doesn't work, people are using but don't know if they work. Your comments on that, and also there's a question here from Ecuador for you, from Riel Quesada. He's saying that he's a physician, his daughter was born last Saturday, and for prevention made the exam for COVID. He has a PCR that's positive. He wants to know how many days he needs to be isolated and how to manage the situation with his daughter. Your comments, please, Dr. Abu, regarding this and regarding the treatments that have been done around the globe, please.
Oh, I think there are two separate questions. So the first question is, I hope that this lecture persuades the people who have been empirically and indiscriminately using azithromycin. I think I understand that desperate times sometimes need desperate measures, but as we have evolved and the science is evolving and we have the same concerns with sudden cardiac deaths, people taking azithromycin and hydroxychloroquine with no EKG baseline or monitoring, prolonged QTs, and sudden cardiac death. And then we don't know if it's thrombosis, myocarditis, or prolonged QT with atorsades from these drugs that are harmful. So I think knowing what we know today, we don't need to keep doing what we were doing 5 or 6 weeks ago. I would discourage the use of this combination unless you're running a clinical trial and you have ways of safely monitoring adverse events. You know, like was mentioned before, first do no harm, and we need to be very careful as we try to do things. Regarding the hydroxychloroquine, I understand the anxiety when we have somebody coming in that you don't know if they're going to progress, and we feel that we always have to do something. I think we need more data. There are trials going on, and I think we need to really start carefully looking at who are we treating with hydroxychloroquine, what dose, and for how long. And I would discourage all these prophylactic hydroxychloroquine in asymptomatic people unless you're also under the auspices of a clinical trial, and there's some clinical trials looking at healthcare workers, but don't self-medicate. Regarding the baby situation, so I would need to have more information, and I'm more than happy to connect with you one-on-one if you want to send me an email or you know, text me, because it depends. Why were you tested? You know, you say you have a positive PCR. Did you have symptoms or were you asymptomatic? How long ago were the symptoms? I need to understand where in the illness are you. Were in the first 5 days, 14 days, or 30 days? And like I mentioned in my talk, we need to understand with the clinical stage in order to interpret the PCR, because the PCR right now is detecting the presence of RNA. It doesn't tell me if it's viable RNA or dead RNA. So I think knowing more, and if there is any way we can do a serology on you that might be helpful, or understanding if we were just recently infected, you need to wait at least 14 to 25 days before coming in close contact with the baby. And we are in our health system, we're testing every woman coming for labor and delivery or emergency section. Every pregnancy patient coming into labor is being tested. The newborns are being tested of the positive mothers, and the partner or the companion is also being tested, and we're isolating them so they don't infect the newborn. So I would err on the side of caution, trying to stay away from the baby. Hand hygiene, which is the most important measure. Don't touch your face, wear a mask. All those things need to happen, and cleaning of the environment are also extremely important regardless of the PCR. I think those are the first measures that you need to take care for your partner and for the baby.
Thank you, Dr. Abu. Dr. Yakeli, there's some question here regarding the use of tocilizumab and the steroids. Please give me your opinion about that, please. And any other comment regarding the answer of the pool.
Thank you for the question to all the attendees. I have not all the results. As I explained, we have many trials ongoing, and I'm an emergency physician, so I have the full idea of all the tests and the trials ongoing in the hospital. Our hospital is the main public research hospital in Italy, so we are currently ongoing many of those trials. I don't have directly practice with favipiravir, for example. So this is one of the questions. So I heard many colleagues, we had just small trials, and apparently they have some results very poor, but I don't have the direct impression, so I can just talk what I heard, but I saw in literature is also not promoted very much, so I'm sure that other the persons who are more curious about his role in COVID-19 outbreak, they could find many other informations, but I have no direct experience. What about the other corticosteroids, especially as other colleagues already explained, we saw some kind of vasculitis, especially vasculitis, and we have a strong immunology department here and a lot of immunology research in this field. So the use of corticosteroids has been started since the beginning, even if some Chinese colleagues show there are no really good experience, but as Dr. Abo at the beginning explained, I think it's really important to understand in which windows, in which time our patients are, and probably different patients and in different moment of the disease, they could maybe be harmed by some therapies, or they could maybe benefit from others. Not all patients have a vasculitis, not all patients have an RDS, not all patients have the same symptoms. We have some cutaneous symptoms, some gastrointestinal symptoms. There are not just respiratory symptoms. So I think the next future will be very important to understand which is the tailor-made therapy for any patients. We saw many different patients. We had hundreds of patients in Italy, especially in my hospital, and we saw a really, from the point of view, from the perspective of the emergency department, we really see many kind of presentation. And I'm actually sure that not all the therapy they could be used at the same stage for everyone, and not all the patients will benefit of all. We probably have different pattern, different, the coronavirus is always the same, but probably not all the clinical manifestation, and they could related with the same kind of pattern. So I think the key role of the research of the trials in future will be understand which patients will benefit of special therapy. In our patients, especially respiratory patients with vasculitis, we saw a huge impact of the corticosteroids, for example, but I can't say that we saw it also in all patients, or even with the gastrointestinal symptoms, for example. So I think we will be it's very hard to answer this question. You know, emergency physicians, they used to work in protocols, so we love to have protocols with us, but in this field, I'm not sure we have is the right approach.
Thank you very much. A question for Dr. Kaul. So when should we start the anticoagulation on these patients? So do you ever start just what point should you anticoagulate this patient? There's a question here.
So I think they should. Yeah. I think they should be started right away. The issue is about risk stratifying them to the highest risk category. So we would monitor D-dimers, for instance, and if the D-dimers were elevated, we would fully anticoagulate them. Some of my colleagues would anticoagulate everyone, but we found complications of bleeding and hemorrhage from that. So we tempered our enthusiasm to try to select a more high-risk group to anticoagulate. So we use the D-dimer, we use the duplex scans to look for any stigmata of DVT and things like that to stratify the high-risk patients. But I think that there's definitely you know, a feeling that anticoagulation is better than no anticoagulation.
Dr. Barrera, tell me your opinion. So DVT prophylaxis or full anticoagulation, and when?
In our experience, everybody gets DVT prophylaxis at admission. And as soon as the patient deteriorates, or we follow D-dimers, we follow all the, you know, because everybody's on a protocol. We have labs every 3 days because of the quantity of patients we had. But if the D-dimers are starting to elevate, we start and we do full anticoagulation. We do have the same experience. Some of the patients we're finding have some subdural hematomas, some have some bleeds also, and it's been troubling. So we're trying to be proactive, trying to see who will require anticoagulation, but there's no clear experience of who does it. But I agree that anticoagulation is better than no anticoagulation, and the earlier the better.
Dr. Abu, your comments based on everything that you read on this topic.
I have mixed feelings. And when I talk to our intensivists who have been managing ARDS way longer than us, they have serious concerns with the bleeding and who truly needs to be anticoagulated. And I feel that I go back to one size does not fit all, that just a blank statement that we should be anticoagulate everyone. We need to be very careful. I think we need to look at the parameters. It's not so easy to get ultrasounds on a daily basis or frequently in these units. The healthcare workers, at least in the US or in Miami, are very, very scared of going and interacting multiple times with the patient, the radiology technicians. So they're asking, do we really need to, you know, go and do frequent ultrasounds, and how frequently we should be doing? So I do think we need to sort of have some guidelines. Like you mentioned, how often do we check the D-dimer? What is the cutoff that we're going to consider? What is the imaging showing, and do things based on evidence and not just anticoagulate everyone from the time you admit them to the ICU. You don't want to delay care, but you have to be thoughtful in when are you doing it. And again, I have mixed feelings within our own division of critical care. Some people are very strongly feeling that we need to anticoagulate more, and some are very opposed. So I think that there has to be some consensus and maybe an algorithm with some exceptions and individualize the care.
Thank you. Dr. Lobi, your comments on this talk, please.
Of course, I only see the patients who are far advanced, but I think that in ARDS in general, there's no particular reason why you did not want to use anticoagulation. I think the statement is true that anticoagulation is better than no anticoagulation in this patient population, and the question is what you use for anticoagulation. In those patients that we treat, it turned out that the majority we end up putting on a gatroban because they seem to have allergies to heparin, which I'm not sure if that's really true or just a test issue. But I mean, that's a rather aggressive way of anticoagulation for sure. So I really would strongly feel that anticoagulation is better than no anticoagulation in any ARDS patient, and in these for sure.
So you can see the answers are completely divided here. So let's go back to Dr. Barrera.
Disease doctor and the intensivist.
No, I said that again, I defer to intensivists, but even within the intensivists, I'm hearing mixed feelings, and it all depends who you talk to. So I think there's no consensus. I think we need to really understand better the rationale for doing it, and again, how to do it safely.
Yeah, no, you're right. That anticoagulation is not part of the standard therapy of ARDS per se. But I'm still, I don't see it.
But this is not just ARDS.
Risk with it.
With a different spectrum of disease. So again, like you know, Alessandro mentioned, you have some patients with vasculitis. I think that's a very different scenario. That somebody who's presenting, with 96 of our patients are not in critical care ICU. They're under the hospitalist service. I don't want people on the webinar to go back to the medical floor, medical surgical wards, and start anticoagulating everybody. I think we need to be very cautious if we think that's the right thing to do or not, and when to do it.
Yeah, I think there are certain.
Yes.
I'm sorry. I think there are certain groups of patients that have renal failure, who may be particularly vulnerable to anticoagulation. And I think, and particularly with the renal effects of phenoxyperin and so on. And I think that, or some patients that may have cirrhosis and other varices. So I think you have to stratify patients, and you can't have a one-size-fit-all for everybody.
Common sense, like it's very important in medicine. So we're gonna go for the final part of this. I want you ask 3 people to comment. So first I'm gonna ask Dr. Barrera to give a quick update about what's happening in Long Island. And then I'm gonna ask Dr. Hayato to talk about 2 minutes about the next phase, about how you see opening the reopening the hospital, elective surgeries. And then ask Dr. Lilian Abu to do the final summary, recommendations for people around the globe. So what she feel for now, maybe changing 6 hours, what should be done. So Dr. Barrera, your updates, please.
Yeah, I have a couple slides, Valeria. Yeah, so as everybody knows, this is where we are in the middle of Queens and the border of Long Island. So this was, next slide, you can leave it there. So this was us. The next slide, Valeria. Next. This was a compilation of the last couple of weeks that we have been dealing with. April the 7th, we had 711 COVID patients on 152 ventilators. April 13, it went up to 723 inpatient, but our ventilator use was down to 110. We had 2 ECMO, and 12% of our patients were discharged to the to home from the ICU, and we discharged 1,000 patients from our hospital. As of today, we have 585 patients, dramatic decrease, only 100 ventilators, 1 ECMO, and 16% of our patients have gone home. And we have discharged from the hospital 1,250 patients. So basically, you can see that we have a vast experience on how to treat these patients, and the most important thing is that the curve is coming down. Next slide. This is how we see it. The graph on the left is basically all the beds in the hospital, and the single one is the ICU bed utilization. As you can clearly see, we're past the peak and going down in bed utilization, and we are starting to consolidate all the peripheral ICUs that we built to one ICU to hopefully start operating for elective surgeries in the next 2 to 3 weeks. Next slide. And next. And this is basically a compilation of Dr. Abo's presentation. This is what we do in the hospital. And as you can see, there's 4 arms of all the trials that we can use: hydroxychloroquine, the remdesivir, famotidine, and nobody gets azithromycin, nobody gets steroids, and these are all the trials we have in the hospital at admission. So I think everybody has agreed into no azithromycin, no steroids, and everybody should be studied, not randomly put on every single medication to see if one works. So this is what we're doing right now in Long Island Jewish, and hopefully by the end of this pandemic, we will have some positive results on the trials. Talking about the anticoagulation, we do have an anticoagulation protocol that, if you want, I can present next week. And the most important thing is that the question I want to ask to the panel is, what about tracheostomies? Who's doing trachs? Who's not doing trachs? We have not trached anybody in our hospital because we are very adverse, secondary to placement. You know, we have too many patients still on vents, and we start traching we have to be very specific who's going to be trached. So I would love to hear what is the experience on everybody else on tracheostomies on these patients. Thank you.
Let's go very quickly. Dr. Kau, are you doing tracheostomy on the patients, and if you're doing when?
Well, we've started doing them. It took us a little while to develop a policy. We have 2 tracheal aspirates negative, and then we do a bedside tracheostomy. And there's an anesthesiologist. It's a multidisciplinary sort of team that identifies who these patients are and whether they should be trached or not. And then we have a trach team that's selected out of the ENT surgeons and the trauma surgeons. and then we sort of rotate. So far, we've only done 2 because it has just been recently rolled out. We wait until they're past their 3rd or, between the 3rd and the 4th week. And if they've had 2 tracheal aspirates that are negative. I mean, it's controversial. It's something that we're worried about.
Okay.
Correct.
Waiting it to be negative, right? Correct. Okay.
Do you do any neurological examination? Evaluation?
I beg your pardon?
Do you have in the protocol a neurologic evaluation?
Yes. The patients have to, they undergo sedation interrupt. The tracheostomies are done only on viable patients. They have to meet criteria for tracheostomy. They have to be viable, i.e. that the tracheostomy is going to help them come off the respirator, which would include having a viable mental status.
Thank you.
Thank you.
Dr. Kurihara, what are you doing regarding tracheostomy in Italy, in Milano, and then your next steps for reopening elective surgery, please?
Oh, so out of 100 of patients that have been intubated and ventilated, I think that we just got 2. And every day, every morning, we have an alert. The intensivists, they need to perform a tracheostomy with the NT guys. And then after the alert, they decide not to do that. So again, very, very selected cases and very controversial. So regarding the all the country is very anxious regarding the stage 2 of this outbreak, and I have just we had just some rumors till now. Probably school will not reopen until September, and probably people will be admitted to go outside, but maintaining a social distancing. So probably some restaurants will be open, probably, but again, they have to rebuild their own respective infrastructure to try to keep social distancing. I don't know if this is going to work, but as you understand, there are a lot of there is a huge economical impact, and especially here in Lombardy, definitively we will have to wear masks for many months, and people are very anxious. The summer season is going to approach very soon, and the Italians want to go to the seaside on the mountains. So regarding the beaches, they are considering to try to find system to have social distances. And we will soon, it will be launched an app like the one that has been used in South Korea, but it's going to work on a volunteer basis. So probably it could be effective if 60% of the Italians will use the app and fill it up correctly, and will be connected by Bluetooth. But as you understand, it's still a big mess, and it's going to be a very long, long way.
Thank you very much for your comments, Dr. Kurihara. So Dr. Lilian Abu, please make a summary of everything that was discussed today. What did you say for patients that have COVID-19 are well at home? What should they do? What should they not do? What do you say? So how do you advise physicians that have patients in-house, but they're not sick enough to go to the ICU? And what do we learn about treating the critical care patients? So please, can you make a summary of this nice webinar that happened today? Thank you, Dr.
I want to congratulate you for putting this amazing panel and participants together for 6-7 consecutive weeks. I feel like every week we learn something more. And I want to say that we will be smarter 4 or 5 weeks from today. I don't think we know yet what is working. We know that some things are not working. We need to start looking at the data of these clinical trials, or start understanding better where have we caused harm and where have we caused benefit. I feel that there's progress being made, And but right now, I cannot with certainty say that there is any therapy that is more effective than other. And if people are talking about combination therapies, should, you know, which combination should we discuss? So the same thing, should we do anticoagulation, or should we do steroids like they're doing in Italy plus an IL-1 inhibitor? All of that data, we need to start looking at the preliminary data, analyzing it, and better understanding what is the evidence in order to proceed. You know, and like everyone mentioned, seems like the curves are slowing in many places. This is the time to analyze what we're doing, to collect more information. In every pandemic, we know that there is a second wave. And as we are trying to lose some of the measures to open the economy and to try to get to a new normal, we really need to be very careful so we don't get to surge in the areas where we have not seen surge. I would say that for people who are asymptomatic, that are at home, probably no therapy at this time is fine. They have been doing well. For people who are developing mild to moderate disease, we really need to determine if hydroxychloroquine has been really helping or not. We need to analyze that information. And for patients that are critically ill, I think multiple things are being tried, and we really need to analyze which one of them are really the ones that are working. We heard differences in management, but I think that everybody is doing the right things with good intentions, trying to study them. And I look forward to seeing in a few weeks the results of those data analysis. I really think that the social distancing and the new normal will have to come into play. As an infectious disease specialist, we've been telling people to wash their hands, and finally, with the pandemic, we saw a 1,000% increase in the consumption of Purell. So people are finally washing their hands, and we're actually seeing a major decrease in hospital-associated infections. Yes, because the volumes are lower, but also people are not passing infections to one another. So I do think the new norm are really the public health measures that need to be in place. I'm very worried about opening the beaches around the world. In Miami, we have 7 miles of beaches. We're not opening the beaches for now. Impossible to monitor and to police the compliance of social distancing in the beaches. So I urge each one of you in your areas to talk to your public health officers and to work with your governors and mayors to really do things in a stepwise approach so we can continue to save lives. So thank you. Thank you for inviting me and everyone for listening and participating.
Thank you, Dr. Abu. Thank you, Dr. Lobi. Thank you, Dr. Kurihara, Dr. Kau. Thank you, Dr. Yaketi, and everybody that participated. Dr. Barreira, thanks for being here again and share your data. In behalf of the Panamerican Trauma Society, the American Association for Surgical Trauma, International Relation Committee, the World Coalition for Trauma Care, and University of Miami, and Virginia Commonwealth University, VCU, I'd like to say that this is a great meeting. We are all working together around the globe to learn together, to understand what's happening. And like Dr. Abu said, in 5 weeks prior to that, you didn't know anything. Now you know something, but probably in 1 month, 2 months, you're going to know more. And at the end, we all want to learn each other and try to treat the patients and to go over this pandemic. For sure, the globe is different, going to be different after this. I cannot wait to meet my friend, Dr. Hayat Kurihara, in person and give him a hug. I hope this is going to happen anytime soon. The conference is going to come back. And I truly believe that in a few months, this is going to be over, and a lot of lessons will be learned from this. Thank you, everybody. See you, everybody, next week. And stay safe and keep working hard and keep helping our patients. Thank you, everybody.
Thank you.